Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University, JAIPUR. Today, we are going to continue from our previous lecture of thyroid disorders. So today we have thyroid disorders 2, and we are going to discuss about autoimmune hypothyroidism. In the previous lecture, we have discussed about hypothyroidism introduction, various clinical features of hypothyroidism. The signs and symptoms we have already discussed. We have also discussed about congenital hypothyroidism, and we had started with autoimmune hypothyroidism. So let's continue with the previous lecture. Autoimmune hypothyroidism is associated with the goiter, that is Hashimoto's or goitrous thyroiditis, minimal residual thyroid tissue, that is atrophic thyroiditis, subclinical hypothyroidism, and clinical hypothyroidism or overt hypothyroidism. Till this we have discussed in the previous lecture. Now we start with the prevalence. The prevalence of autoimmune hypothyroidism is the incidence rate of autoimmune hypothyroidism is up to 4 per 1,000 women and 1 per 1,000 men. It is more common in females with the ratio of 4:1. The pathogenesis, there is marked lymphocytic infiltration of the thyroid atrophy of the thyroid follicles, and there is absence of colloid and mild to moderate fibrosis. The clinical manifestations of autoimmune hypothyroidism includes the onset is usually insidious, the goiter may not be large, but it is usually irregular and firm in consistency. The skin is dry and there is decreased sweating, thinning of the epidermis, and hyperkeratosis of the stratum corneum. There is increased dermal glycosaminoglycan contact, trap water, giving rise to skin thickening without pitting, that is myxedema. So you have to remember this term, glycosaminoglycans, which causes thickening or pitting, that is myxedema. There is puffy face with edematous eyelids and non-pitting pretibial edema. The skin is pellar, often with a yellow tinge to the skin due to keratin accumulation. The nail growth is retarded and the hair is dry, brittle, difficult to manage, and falls out easily. There is thinning of the outer one-third of the eyebrows with constipation, weight gain despite of poor appetite. There is libido, that is decreased sexual drive in both the sexes. There is menorrhagia with fertility is reduced, the incidence of miscarriage is increased. So we have pellar, we have nail growth is retarded, we have thinning of the outer one-third of the eyebrows, constipation, weight gain, loss of libido, and menorrhagia. This is the clinical features with hair dry, coarse, sparse, lateral thinning of the eyebrows, periorbital edema, puffy, dull face of dry skin, and this is the picture of pretibial myxedema. Now, we have myocardial contractility. The other clinical manifestations includes myocardial contractility, and the pulse rate are reduced, leading to a reduced stroke volume and bradycardia. There is increased peripheral resistance with diastolic hypertension. The blood flow is diverted from the skin and it produces cool extremities. The fluid may be accumulated in other serous cavities and in middle ear, giving rise to conductive deafness. Now the lab evaluation. In lab evaluation, we have to conduct TSH and T4 levels. We have to see for the demonstration of TPO, that is thyroid peroxidase antibodies, that are present in 90% of the cases. There is fine needle aspiration biopsy to confirm the presence of autoimmune thyroiditis. We have ultrasound, and the differential diagnosis is an asymmetric goiter in Hashimoto thyroiditis that may be confused with multinodular goiter or thyroid carcinoma. The other causes of hypothyroidism includes iatrogenic hypothyroidism that is seen in first 3 to 4 months after radioiodine treatment. Transient hypothyroidism may occur due to reversible radiation damage. Because of the TSH levels are suppressed by hyperthyroidism, unbound T4 levels are better measured of thyroid function. Iodine deficiency is responsible for endemic goiter and cretinism. The secondary hypothyroidism is due to another anterior pituitary hormone deficiencies. That is, TSH level may be low, normal, or even slightly increased. The diagnosis is confirmed by detecting a low unbound T4 levels, and the treatment is to maintain T4 levels in the upper half of the reference range. Next, we come to the lab evaluation of hypothyroidism. This is in general. Previously, we had discussed about autoimmune lab evaluation. Now we come to the lab evaluation in general of hypothyroidism. We have to measure the thyroid hormone, that is doing the TSH assay. Test to determine the etiology of the thyroid dysfunction, circulating autoantibodies against TPO and thyroglobulin. Radioiodine uptake and thyroid scanning, that is radioisotopes of iodine I-123, 125 and 131, and M99 technetium. And we also have to go for thyroid ultrasound. Now we come to the management of hypothyroidism. The management of hypothyroidism consists of daily replacement dose of levothyroxine. It is usually 1.6 microgram per kg body weight. Special consideration in women with history of high risk of hypothyroidism should ensure that they are euthyroid prior to conception and during early pregnancy, because maternal hypothyroidism may adversely affect fetal neural development and cause preterm delivery. The absence of thyroid and autoantibodies alone in a euthyroid patient is also associated with miscarriage and preterm delivery. So this was all about hypothyroidism. In the next lecture, we are going to discuss about thyrotoxicosis. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow.